Welcome and thank you for your time today. We are coming to you in representation of the Minnesota Home Care Association members and the Workforce Committee. Members of the committee have collaborated to highlight home care nursing history, opportunities, and overall perspective. Our objectives today are to learn more about the Minnesota Home Care Association, learn about the history of home care, learn about the evolution of home care, and learn about the role of the home care nurse in home care.
Minnesota Home Care Association has its roots as a council of the Minnesota League for Nursing in 1970 and was called the Assembly of Home Health Nursing Agencies. Its purpose was to grow and work together in the ever-changing field of home health care. As the home health care industry expanded to include hospital-based and proprietary agencies, the goal was to assist the newly developing agencies with their needs while maintaining an emphasis on public health nursing delivery of home care. With a vision to shape the home care landscape to improve and sustain quality home care services, Minnesota Home Care Association represents and supports Minnesota home care providers committed to high-quality home care services. The association advocates for and educates providers around the state.
Today, one of our challenges for our providers is facing the workforce shortages. In recognizing that many of our nursing students are not aware of home care careers, we are now advocating for students to consider this a highly rewarding career. This recorded webinar is an introduction to home care world and will be followed up by an additional webinar that shares about how nursing programs and providers can work together to teach students about career options. We appreciate you taking the time to learn more about home care. How would home care fit into your curriculum, and what type of structured partnerships would you like to see? Would you be open to use home care agencies as a clinical site for rotation for your students? What did the future of nursing look like in the 19th century? Florence Nightingale is referred to as the founder of modern nursing. She was also an early researcher. Nightingale took meticulous notes and was one of the early statisticians on sanitary conditions and mortality rates. She used statistics to analyze social conditions and the effectiveness of public policy. She was influential in the allocation of resources. As a female in the 19th century, Nightingale was ahead of her time. She was visionary in how she saw the big picture and had a clear sense of purpose. Florence Nightingale had a vision for home care, and I wanted to share a quote with you today about that vision. My view, is that the ultimate destination of all nursing is the nursing of the sick in their own homes. But no use to talk about that until the year 2000. And in the early visiting nurses in America, they were called district nurses. The term was introduced by Nightingale for nurses who visited the sick and provided health teaching in communities. The first home visiting program in the United States appeared in the 1880s. Now let's talk about the evolution to better understand how we got to where we are today.
What was a home care nurse's day like 30 years ago? Communication. Their day would always start in the office and they would have assignments. The nurses would number their patients if they needed to be contacted throughout the day. What this meant is that the staff in the office would need to call the patient's landline to see if they had arrived or left. Some patients did not have telephones. Sometimes the home care nurse would need to contact the physician immediately and would need to use the patient's phone, which in many cases was a long distance telephone call. If there was an emergency, the nurse needed to contact the local ambulance for transport. 911 calls weren't set up in the rural communities until the mid-1980s. Nurses needed to know where payphones were located along their travel route to make calls. The nurse would end the home care nurse day in the office to make follow-up phone calls and complete documentation. The plan of care was kept in the office, and sometimes it would take all day for a plan of care change due to phone calls that needed to be completed with the physician's office nurse and the home care nurse. Documentation. The office would have dictaphones, and the home care nurse would complete all their documentation by dictating. A secretary would type all these notes, and sometimes it would take several days before this documentation would appear in the chart. Travel. When home care nurses called the patients, they would ask for directions. Of course, sometimes the house had been painted or the fence that was important was blown down, so at times they were lost. If the home care nurse was lost and needed directions, they would stop by a neighbor and ask for those directions. Plat books and maps were part of the nurse's tools of the profession. Durable medical equipment. DME companies did not exist in central Minnesota, and supplies and equipment needed to be provided by the hospital. Nurses would need to pick up supplies from the hospital and then deliver them to the patient's homes. Meetings. They were all completed on site and in person. Continuing education or mandatory education. Home care nurses attended live education sessions or completed education with books or magazines. Then would need to mail completed tests to the organizations for continuing education credits. Nurses usually were assigned 2 to 3 patients a day. The early days of home care. Home care in central Minnesota evolved in the 1980s. An orthopedic patient that had a total knee replacement would stay in the hospital anywhere from 7 to 14 days in the late 70s and early 80s. The physician specialists reviewed length of stay and then thought the hospital could be shortened if they had one of the specialty nurses from their unit make several home visits. Nurses would make home visits after they had worked their shift. This was the beginning of home care in central Minnesota and the specialty it has become. Today, patients that have a total knee replacement without any underlying health issues will spend 1 to 3 days in the hospital and then discharge home with skilled nursing visits and physical therapy visits for 3 weeks. Early discharge to home with home-based rehabilitation and physical therapy has been associated with reduced costs, improved clinical outcomes, and increased patient satisfaction. Julie, age 67, living in St. Cloud, had a total knee replacement in January. Before the surgery, she got a list of things she needed to do to prepare for her recovery. Afterward, a nurse and physical therapist visited her at home regularly for about 3 weeks. I was more comfortable recuperating at home, and I've had absolutely no complications, she said. For pediatrics, in the early days of home care, high acute technologically dependent pediatric patients lived in the hospital. Today, these children are able to live at home due to skilled home care nursing and the ability to create a mini ICU and/or vent weaning setting in the home, where home care nurses collaborate with dietitians, respiratory therapy, and specialty physicians for patients to progress at home more quickly than the past extended hospital stay in the PICU. Children are growing up at home. An example is a 23-week premature infant born with extremely low birth weight and a history of malnutrition, thrombocytopenia, cerebral hemorrhage, surgical closure of an atrial septal defect, complicated by bronchopulmonary dysplasia. The child with a tracheostomy and ventilator dependence was able to go home at 7 months of age. She is scheduled to be decannulated at age 3. Without home care nursing, she would have lived her life in the hospital until she was weaned from the ventilator and decannulated. Medically complex children are thriving at home due to home care nursing. Technology, then and now. In the earlier times of home care, a large amount of time was spent in the office because that was where the phones were, plan of care documents, dictation equipment, word processors, and all in-person meetings were held. The car phone service became popular and mainstream in the 1970s. The cell phone's car radio phone technology connected with the car's battery and used signals that were attached to telephone networks. The original phone weighed 80 pounds and had limited telephone coverage. There were no technology or virtual meetings or televisit options. In-home technology was limited. Pulse oximeters were first introduced in the US in 1981 and was the first device to provide a non-invasive way to measure a patient's oxygen levels. The first in-home ventilator was not FDA approved until 1977, and the reimbursement milestone did not occur until 1981. Technology has changed to now the life of home care nurses. In most cases, it is not the expectation that nurses need to come into the office. Cars are equipped with many comfort and computer features. Home care nurses have cell phones with GPS that you can get directions to patients' home or call patients or physicians when needed. Computers are used for documentation in the home, plan of care, communication, and medication updates with the patient visit. Nurses call or send a computer message to the physician or nurse pool for immediate response. Nurses update their own schedules. Supplies are sent to patients' homes or nurse homes. The use of safety devices is now used for monitoring home visits. One example is the safe signal that is used with the phones and pulled when needed and the police arrive. Meetings for staff are completed by WebEx or Zoom, and continuing mandatory education can be completed on the computer. Changes over the years that have impacted home care in the 1990s and 2000s includes the increasing inpatient stays have led to rising medical costs in the 90s, along with people wanting to age in place in their own home. Increased technology increased pediatric life expectancy and resulted in longer pediatric stays, having impacted home care with the move to treat and serve patients in their home. In the 2000s, the move to decrease hospital stays to reduce cost, the need for medical care in the home, move to ambulatory and the home care setting. Changes in reimbursement to meet and reduce these costs occurred as seen in the increased in-home care reimbursements and revenue sources. With the move to in-home care, it has reduced hospital stays and increased the acuity and medical complexities when patients are discharged to home care with the increased in clinical outcomes and patient-centered care. The 1990s, we see payer changes with rising costs and reductions in reimbursements did occur. Episodic payments and a care model was introduced. The OASIS assessment was used to gather outcomes data. Payments were now based on patient acuity rather than the number of visits. This limited Medicare spending, which reduced reimbursement. Agencies that billed Medicare and Medicaid were required to gather data from the Outcome and Assessments Information Set, or OASIS tool. This tool is used to identify severity of illness, disabilities, and nursing needs. The aging baby boomers. The desire to age in place has spurred the demand for home care services. As people live longer, there is a focus and intent to remain independent for as long as possible, delaying or avoiding admissions to costly long-term facilities. The clinician skill set. The home care nursing skill set evolved to include specialized knowledge and expertise, including home infusion, mental health, care of complex pediatric patients and adults with long-term healthcare needs, and more. This spurred the need for specialized education programs and preparation. Education programs. Opportunities for clinical practice that specialized in the home care setting were limited. Nursing educators were tasked with developing programs to include the skill set and knowledge needed to support growth and interest in home health nursing. In the 2000s, we also see payer changes. Healthcare models demonstrate significant movement of care from inpatient settings into the ambulatory and home care setting. This is reflected in home care reimbursement dollars that are geared towards agencies that demonstrate preventative measures and improved patient outcomes. Aging baby boomers continue to affect home care. As the number of patients with multiple chronic conditions continue to rise, home care nurses are entrusted to provide effective patient-driven care. Effects of these chronic conditions on healthcare spending are massive. Clients are becoming increasingly engaged with their care, and home care nursing is at the forefront of empowering clients. Client preferences and satisfaction are key drivers of performance. Remaining independent for as long as possible is a challenge. High acuity and complex patients served at home. With the increase in medical technology, high acuity and complex pediatric and young adult clients are able to live at home with skilled nursing. Adult chronic clients choosing life-sustaining technology and interventions are also served in the home. The clinician skill set. Specialization of home care nursing includes managing complex patients and conditions at home rather than inpatient settings. This includes managing ventilators, dialysis, chemo infusions, and utilizing technology that once was only available in hospitals. Home care nurses are adept at diagnosing, treating, and prevention. Education programs. To meet anticipated home care demand and growth, educational programs that highlight and offer home health nursing as a specialty is a goal. Curriculum that include clinical practice and residency programs which partner with hospitals, DME, and other healthcare organizations is essential.
In this last year, we have all been challenged with rethinking how our roles in our communities are in response to the COVID pandemic. The state survey process and quality assurance focus during this demands of this last year continues to revolve around infection control and quality assurance, balancing safety and combating the effects of isolation for our clients is our new norm. The pandemic has also created issues with PPE procurement and distribution. Staying on top of that demand is now a big part of our role within home care. Innovative thinking is now required to meet the needs of our clients in the new world of quarantine. Virtual visits and telehealth has taken a leap forward in development and implementation. Devices can now be used as a training tool for our clients, caregivers, and nurses. Client care has evolved. Rapid response to meet the needs of our community has put home care at the center stage. We are essential, and we are a part of the care continuum in the community and response planning. 2020 showcased how the home care industry responds to challenge, utilizing critical thinking, innovation, problem solving, all while keeping the client at the center of our care. Home care welcomes new grads. We truly feel it's an environment that provides that concentrated yet diverse experience that they are looking for. Working one-on-one with a client, yet focusing on the one person holistically can give that new grad the confidence and attention needed for success. Managing the onset of one set of treatments, one list of medications, into one organized care plan that is empowering. Staying with that patient long enough to see true outcomes and developmental goals achieved is very fulfilling. I would like to share a testimony with you now of a new grad that found her first job within home care in a pediatric setting.
Hi, my name is Rachel. I'm a registered nurse, and I've been working in home care for the past 6 months. So when I was in nursing school, I didn't learn anything about home care. I only learned about it because of an outside resource. We mostly just learned about ICU positions, emergency department, that sorts of things. Those are the only types of nurses I really heard about or heard from. So I think in nursing school, it would have been nice to know there's a different option than this intense ICU, emergency department, because that's not for everyone. Even one day, just to learn about what it means to be a home care nurse would have been very helpful, I think, to a lot of people. My senior year, I went to a career fair and I was just talking to one of the stands, Recover Health, and they just told me about home care and what it was and the one-on-one and autonomy that you get with it, and that was my first time experiencing any kind of knowledge about home care. The reason I wanted to start my career in home care was when I was in my clinicals in the hospital, I just felt a disconnect from my patients because I was seeing them for 8-12 hours max, and I felt like I really didn't get to know them. As soon as I learned about home care, I was really excited because it's that one-on-one connection that you have. You really get to know someone when you're with them for 10-12 hours, a couple times a week, once a week, whatever it is. But you just know them, and then you can just put that much more compassion and care into your nursing. And I just loved the independence and the autonomy that came with it. I felt like I could really grow as a nurse when I was in there doing it on my own. I was the nurse that the patients were relying on. Home health care is rewarding to me because I'm really able to see the growth and the outcomes of my patients. You're with these people for months and months and months, so you kind of can really see how they do over time, how your specific nursing interventions are helping them grow and develop. I have a baby that's a high acute baby that did not have a great prognosis, but through our nursing interventions, I'm able to see how much better he's doing in home and how much he's developing more than we ever could have imagined. And it's just very, very rewarding to know that you had an impact in helping that family and that client really grow. One of the most important things to me is making sure that I am being accommodating to them and empowering them in their homes and with the care of their loved one or themselves, and really working as a team rather than me being the medical professional and them just being the client, but working as a team to get the care that they need and making sure that they understand everything that is happening and feeling comfortable with everything.
So success of a home care nurse develops many skills and strengths valuable to their success. A home care nurse is, when we think about that, we think of all the different things that they need to obtain, but yet bring to the table in their career in home care. So we think of the critical thinker, out-of-the-box problem solver, a great teacher, a reliable individual, patient-centered with focus on skilled interventions, as well as seeing the big picture clinically. Communication, both written, verbal, also documentation, triaging, and follow-through. The documentation skills, such as creating that picture of what that patient is, what that client is demonstrating at that moment when involving the care continuum. Flexibility, relationships, aptitude in managing trusting relationships in a home setting. Boundaries, compassion of nurses and working in different environments is in a home bedside setting versus facility or clinic. Cultural sensitivity and self-motivation. Home care is the future. There will be fewer and shorter hospital stays. More people will be cared for in their own homes. We are excited to share ideas and how the Minnesota Home Care Association providers can work with the nursing programs to increase awareness of home care as a career and help orient students to the home care industry. Join us for the follow-up webinar that is also taking place and is available for you to learn more about the career ladder and how we can partner with you to offer students more options. Let's work together on this win-win partnership. Thank you for your time today, your expertise, and your desire to create the Minnesota nursing workforce of tomorrow. We would greatly appreciate, in the completion of this video, a quick 5-question survey so we can get your insight. Let us know how you found this helpful and how we can work together to build a stronger home care workforce and help the success of your nursing students. Thanks so much for joining us today.